Hello to all of you. Today we will tell you about the link between high blood pressure and pregnancy. Let's start. What is high blood pressure? Hypertension. Blood pressure is the pressure that the blood exerts on the walls of blood vessels every time the heart beats and pumps blood. High blood pressure is called hypertension. Hypertension is diagnosed if the upper blood pressure is E 140 mmHg or the lower blood pressure is T 90 mmHg. How is blood pressure measured? Since the diagnostic criterion for hypertension in pregnancy is high blood pressure, accurate measurement of blood pressure is very important. Blood pressure is measured in a sitting or semi-sitting position. The arm to be measured should be aligned with the heart, and the arm should be at a 45 degrees angle. There should be an appropriate size cuff, large cuff if 33 centimeters. It should be measured after resting for at least 10 minutes. No smoking or caffeine use at least 30 minutes before. Two measurements should be taken at least 4 hours and at most 1 week apart. However, if the blood pressure is high in the first measurement, the interval required for the second measurement may be shorter. Why is hypertension important in pregnancy? The most common health problem during pregnancy is high blood pressure, hypertension. It occurs in 5–10% of pregnancies. It is the third cause of maternal mortality worldwide, but the second cause in Turkey. Severe or uncontrolled hypertension during pregnancy causes serious problems for you and your baby. The prevalence of hypertension in pregnancy has increased by 25% in the last 20 years. Some risk factors for this increase are as follows: obesity, diabetes, multiple pregnancy, advanced maternal age. What are the increased risks for the mother due to hypertension during pregnancy? Conditions that increase the risk of development in the mother due to hypertension during pregnancy are as follows: detachment, disseminated intravascular coagulation, acute respiratory distress, pulmonary edema, aspiration pneumonia, acute renal failure, liver damage, hemorrhage, failure, brain hemorrhage, stroke, hypertensive encephalopathy, death. What are the increased risks for the fetus due to hypertension during pregnancy? There is an increased risk of the following conditions in the fetus due to hypertension during pregnancy: growth restriction, premature birth, amniotic fluid deficiency, death in the womb, increase in cesarean section frequency. What are the diseases of hypertension during pregnancy? Hypertension during pregnancy is divided into 4 groups according to the time of onset and how it affects the body. Chronic hypertension, gestational hypertension, preeclampsia. Preeclampsia associated with chronic hypertension. What is chronic hypertension? High blood pressure detected before conception or before the 20th week of pregnancy is called chronic hypertension. Hypertension is diagnosed if large blood pressure, systolic, 140, and/or small blood pressure, diastolic, 90 mmHg. It is due to causes such as essential hypertension or underlying kidney and hormone diseases. You are considered chronic hypertensive even if you conceived using pre-pregnancy medication and your blood pressure is normal. Since blood pressure normally decreases in the second trimester of pregnancy, blood pressure may remain normal in patients with chronic hypertension during this period. There is high blood pressure that is carried beyond 12 weeks after birth. It is classified as mild, POS 179 109 mmHg, and severe TATOS 180 110 mmHg according to its severity. It is more common in pregnant women with advanced maternal age. Medications should be reviewed before conception. Methyldopa is the safest. Calcium channel blockers may also be used. Angiotensin converting enzyme, ACE inhibitors are not used in pregnancy because they cause structural abnormalities in the fetus. Depending on the severity and duration of high blood pressure, the frequency of problems caused by both mother and baby increases. What are the problems associated with chronic hypertension? Problems that may develop in the mother due to chronic hypertension are as follows: severe increase in blood pressure, development of preeclampsia, heart failure, brain hemorrhage, kidney failure, detachment problems that may develop in the baby due to chronic hypertension include prematurity, developmental delay, amniotic fluid deficiency. How is chronic hypertension managed? In this group of pregnant women, blood pressure, laboratory tests for organ damage, the development of the baby, and the amount of amniotic fluid should be monitored. The patient should be educated about the leading signs of complications and awareness should be raised. Treatment may require discontinuation of the drug, adjustment of the drug dose, or addition of another drug. The goal is to keep blood pressure below 150/100 mmHg. If there is organ damage due to hypertension, such as kidney or eye damage, then a blood pressure below 140/90 mmHg is desirable. Nevertheless, the small blood pressure, diastole, should not fall below 80 mmHg. The pre-pregnancy medication can be restarted within 2 days after delivery. What is gestational hypertension? High blood pressure that develops after the gestational week or in the first 24 hours after delivery is called gestational hypertension. Diagnostic criteria: high blood pressure, systole 140 or diastole 90 mmHg, but systole 160, diastole 110 mmHg. Previously normal blood pressure, no protein in urine, no additional complaints. The diagnosis is often made retrospectively. Patients with high blood pressure who do not develop any complaints and laboratory findings, and whose blood pressure returns to normal in the first 3 months after birth, constitute this group. Although high blood pressure regresses after birth, these people are candidates for hypertension in the future. What is preeclampsia? Preeclampsia is a serious blood pressure disease that can affect all organs in pregnant women after 20 weeks of gestation. When a pregnant woman with hypertension has complaints and findings related to the affected organ disorder, or is accompanied by laboratory findings, it is called preeclampsia. Clinical findings occur according to the system involved: swelling in the hands and face, headache, flies in the eyes, blurred vision, upper abdominal pain, nausea, vomiting, sudden weight gain, and respiratory distress are the complaints seen in patients. One of the laboratory findings is proteinuria, protein in the urine. What is proteinuria? The presence of protein in the urine that should not normally be present is called proteinuria. The most commonly used method in the diagnosis is the total amount of protein in the urine, 300 mg a day. In addition, a urine protein to creatinine ratio of 0.3 is another diagnostic method. Another diagnostic method is a protein level of Mu+1 in at least 2 urine samples analyzed with a dipstick, a stick made of a special paper dipped in urine, at 4 6-hour intervals. In this last method, plus 1 protein equals sign 0.3 gl plus 2 protein equals sign 1 gl plus 3 protein equals sign 3 gl corresponds to proteinuria. Who is at risk of developing preeclampsia? Pregnant women with the following risks have an increased frequency of preeclampsia. First pregnancy, limited exposure to semen, condoms, in vitro fertilization, donor sperm age, 18 or 35 family history of preeclampsia, mole hydatiform paternal father, history of preeclampsia, personal history of preeclampsia interval between 2 pregnancies, 10 years, fetal hydrops, multiple pregnancy, gestational trophoblastic disease, obesity, BMI 30, chronic hypertension, gestational diabetes, type 2 diabetes, insulin resistance, connective tissue diseases such as SLE, vascular diseases, kidney disease, thrombophilia, antiphospholipid syndrome. How is preeclampsia classified? Preeclampsia is classified according to the time of onset and severity. Early onset, if it develops before 34 weeks of gestation. Late onset, if it develops after 34 weeks. Sometimes preeclampsia may also develop postpartum or at the time of delivery. According to the severity of laboratory findings or complaints in addition to hypertension, mild it is divided into 2 as severe. Severe preeclampsia. It is divided into mild and severe preeclampsia according to the degree of laboratory findings and severity of complaints. Severe hypertension, systole dose 160 mmHg or diastole dose 110 mmHg. A thrombocyte count below 100,000, creatinine 1 mg/dl in newly impaired renal function tests, more than doubling of enzymes in liver function tests, upper abdominal pain, nausea, vomiting, visual disturbance, blurred vision, appearance like flies flying in front of the eyes, behavioral disorder, panic, headache unresponsive to treatment, fluid collection in the lungs are the signs of severe preeclampsia. Which risks increase in pregnant women with preeclampsia? Pregnant women who develop preeclampsia during pregnancy are at risk for the following diseases: cardiovascular diseases, heart attack, hypertension, stroke, kidney failure, retinopathy, risk of recurrence in the next pregnancy, development of eclampsia, development of HELLP syndrome. What are the fetal neonatal complications in severe preeclampsia? The increased risks for the fetus and neonate in severe preeclampsia are as follows: preterm labor, severe growth development restriction, oligohydroamnios hypoxia, acidosis, neurological damage, perinatal mortality, cerebral palsy. What is eclampsia? The development of convulsions in a pregnant woman with preeclampsia is called eclampsia. Sometimes it may develop even in pregnant women with only mild high blood pressure. The cause is not known exactly. Low oxygen and blood supply to the brain and brain edema are blamed. 53% of convulsions develop during pregnancy, 19% during labor, and 28% in the puerperium. What is HELLP syndrome? HELLP syndrome is a medical emergency. It can cause long-term permanent organ damage, even death. The clinical picture develops due to bleeding, elevated liver enzymes, and low coagulation cells. What is superimposed preeclampsia? Preeclampsia developing on the background of chronic hypertension is called superimposed preeclampsia. It is characterized by sudden, persistent, progressive hypertension, either 1C110 mmHg, and or new proteinuria, and or a progressive and persistent increase in existing proteinuria, often more than doubling. Proteinuria is often more than doubled, progressive, and persistent. However, its severity does not guide treatment. How are gestational hypertension and mild preeclampsia managed? Both of these conditions can be managed as outpatients. It is ensured that the pregnant woman stays at home and rests and avoids stress and fatigue. Strict blood pressure, weight, and edema monitoring is performed. How are gestational hypertension and mild preeclampsia managed? The pregnant woman monitors herself for signs of severe preeclampsia. The mother follows the baby's movements. According to the complaints, the patient is called for control once or twice a week. How is severe preeclampsia managed? Preeclampsia carries risks for both the mother and her baby. However, it is a disease of the mother. The most basic approach is early detection and delivery to minimize the risks. There is no medical treatment. If the pregnancy is term, the decision is easy. Delivery. When deciding on delivery, the increased risks due to the continuation of the condition and the risks that may develop in the baby due to premature delivery are weighed. If the pregnancy is not close to term, the pregnant woman is hospitalized and closely monitored. Laboratory tests are repeated at regular intervals. The baby's development and the amount of amniotic fluid are monitored. The baby's blood flow values are measured and the baby's well-being is checked. The goals of treatment are to prevent the development of eclampsia, to lower blood pressure, and to delay the time of delivery. How is labor timing done? The definitive treatment for preeclampsia is labor. The mother is given medication, corticosteroids, for the baby's lung development. Labor is started 24 hours after this administration. However, if severe symptoms that do not respond to treatment persist, organ failure is detected, placental detachment develops, or the baby's condition worsens, the pregnant woman is delivered without waiting. While there's 38 weeks gestation in gestational hypertension and mild preeclampsia, 38 weeks in chronic hypertension. The mode of delivery is determined by fetal gestational age, fetal presentation, and maternal fetal status. The first choice for delivery is vaginal delivery because lung function is also impaired in patients with preeclampsia. The chance of vaginal delivery decreases with decreasing gestational week. What is the type of anesthesia? General anesthesia is preferred if intubation is difficult due to airway edema or severe hypertension. If the pregnant woman needs an emergency cesarean section, epidural spinal anesthesia is preferred over general anesthesia. However, care should be taken if the platelet count is 50 minus 100,000 or if there is a tendency to clot. What is the postnatal management? Blood pressure monitoring is continued according to the general condition of the puerperant. Blood pressure is measured every 4 hours for at least 2 days. Serious postpartum complications are especially high in patients with chronic hypertension. Postpartum 3, 4. If blood pressure 150-100 mmHg, blood and biochemistry are normal, the puerperant is discharged. In 2 weeks, she is called for control. In this period, blood pressure should be measured 2 times a day, and if normal, treatment should be discontinued. Blood pressure is tried to be kept at systole 160 and diastole 100 mmHg. If blood pressure 130/80 mmHg, the drug is discontinued. If methyl-dopa is taken during pregnancy, the drug is changed within the first 2 days. In those who do not need to start blood pressure medication during pregnancy, medication is started if blood pressure 150/100 mmHg after delivery. In chronic hypertension, especially in superimposed preeclampsia, Non-steroidal anti-inflammatory drugs cause blood pressure rise by retaining sodium. They should be avoided. Methyl-dopa and Ca++ channel blockers have the lowest rate of excretion into milk. From the S-blocker group, labetalol or propranolol should be preferred. Metoprolol, atenolol are highly excreted in milk. ACE inhibitors are safe, example captopril. Diuretics are safe, but reduce milk. If severe hypertension persists despite two antihypertensive drugs, the patient should be referred. The presence of secondary hypertension should be investigated. Normalization of blood pressure after delivery may take up to 12 weeks. People who exceed this period are candidates for chronic hypertension. They are referred to an internal medicine specialist. Preeclampsia and eclampsia should not be forgotten after birth. Eclampsia may also develop after birth, especially in the first 48 hours. Therefore, preventive treatment, magnesium sulfate, started before delivery is continued. Sometimes preeclampsia and eclampsia may develop for the first time after labor, and the picture may become more severe before recovery. If you develop severe symptoms of preeclampsia, inform your doctor immediately. However, severe hypertension, bleeding, or problems due to anesthesia may leave sequelae. Can preeclampsia be prevented? Prevention is only possible by checking for the presence of risk factors and acting accordingly. The patient with chronic hypertension should be examined before pregnancy. It should be checked whether the blood pressure is under control. It should be determined if there is organ damage. It should be switched to options in accordance with the categories of drug use during pregnancy and those who use drugs. If the patient is overweight, the patient should lose weight. If you have an additional condition such as diabetes, it should be controlled. In patients with chronic hypertension, kidney disease, lupus, antiphospholipid syndrome, diabetes, and those who developed preeclampsia in the previous pregnancy, baby aspirin, 75 mg day, should be started after the 12th week of pregnancy. If the following two factors are present together, aspirin is also recommended. First pregnancy, age, plus 40 years, previous pregnancy, 10 years ago, BMI 3kg/M2 at the first examination, family history of preeclampsia, multiple pregnancy. Vitamin C, vitamin E supplementation, salt restriction, and bed rest have not been shown to be beneficial. What is low-dose aspirin administration? Aspirin prevents blood clotting, suppresses thromboxane synthesis, reduces platelet activation in the placenta, prevents thrombosis, reduces the risk of preeclampsia by 19%, and fetal death by 16%. Aspirin 150 milligrams daily at night before bedtime, continued from 12 weeks until 10 days before delivery. What long-term problems do people with hypertension during pregnancy experience? People who develop preeclampsia during pregnancy have an increased risk of hypertension, diabetes, and heart disease in the future. Therefore, if high blood pressure persists for more than 12 weeks after delivery, an internist should be consulted immediately. For those whose blood pressure returns to normal, lifestyle changes, regular exercise, healthy diet, weight loss, regular blood pressure monitoring, and control of metabolic factors are recommended. These people should have regular kidney and heart function and eye examinations. Thank you for watching.